Yeah. So
Okay.
good evening to all participants of today's classroom. So I'm very honored. I'd like to welcome all, especially to Girish Misraji as an expert in this subject of parotid, and Dr. Kunal Ranjan as a speaker
Excuse me,
of
your voice is
parotid
not
tumor,
clear, sir.
and Dr. Hirenda.
Your,
I think
your
he
voice
is in
is
Shillong.
not clear.
Voice is not
Okay.
clear.
He is in Shillong.
Voice is not clear because of.
You can stop your video and you can use your audio.
Welcome to this August meeting. Thank you.
Yeah. Okay. Dr. Anjan, kindly
Thank
unmute
you.
yourself, Dr. Anjan. Yeah. Just
Yes,
introduce.
sir. Hello, good evening, everyone. It's my proud privilege to introduce Dr. Girish Mishra, sir. He is one of my mentors during my early career. So when I joined as an assistant professor in Gujarat, so he has the HOD and I learned a lot from him.
Next.
So he's a distinguished otolaryngologist and head and neck surgeon. Dr. Mishra, sir, served as a professor and head and neck. Can you hear me, sir?
I can
Yes,
hear
Am I
you,
yes.
but
audible?
voice keeps
Yes.
on trembling, you know.
Can you hear me, sir, now?
Yeah, we can hear you.
You are good.
Okay. So, Mr. Sir is working as a professor and head of otolaryngology and head and neck surgery at PS Medical College, Karamsad, Gujarat, with over 20 years of leadership in advanced ENT and cancer care. He has received specialist training at premier institution worldwide, including Tata Memorial Hospital, Mumbai, Memorial Sloan Kettering Cancer Care, New York, MD Anderson Cancer Center, Hudson, House Ear Institute, Los Angeles, and Royal Victorian Eye and Ear Hospital, Melbourne. So his exceptional work has earned him the RAF Cooper Gold Medal and the Dr. S.D. Parikh Award. He has led ICMR and WHO project on cancer mapping and survival pattern and tobacco cessation, establishing Gujarat's only WHO recognized tobacco cessation research center. Recognized globally for his expertise in head and neck cancer surgery, otology, cochlear implantation. Dr. Mishra is also a life member of leading ENT and otology bodies worldwide. So, with that short brief, I would like to welcome Mr. Sir, and please join me extending a warm welcome to Dr. Girish Mishra, sir.
Thank
So
you.
we welcome you.
Anjan, for fine introduction.
Now,
Swagata
over to
ma'am.
Swagata ma'am
Yeah.
for introduction of our
Anjana
speaker.
ma'am.
Yeah.
Yes,
Hello. Madam,
yes, yes.
is there any problem in audio? I'm not getting any sound from
This
there.
is from your end. Who is speaking actually?
Hirenda, you should check your audio because we are getting the sound. Your audio may be.
Sadiguna, you can go out and again join.
So can I start now?
Yes, yes, ma'am.
Yeah. Good evening, everyone, to Naboy Classroom. So today's speaker is Dr. Kunal Ranjan. I'm very glad that today's he is among us. He was once my PG student. He did under me when I was in Guwahati Medical College. He did his MS from Guwahati Medical College, and after completion of MS, he went for fellowship in head and neck and oncology, microvascular reconstruction from BBCI, B. Borua Cancer Institute. Presently, he is senior consultant of head and neck oncology at Mahavir Cancer Sanstha, Patna. He also is a faculty and examiner for head and neck oncosurgery under National Board of Examination. Our learned moderator, Dr. Dhiren Kumar Nath, senior consultant at Northeast Cancer and Spit Hospital, Jurabad. He passed MBBS and MS board from Guwahati Medical College. Also trained at Tata Memorial Hospital, Mumbai. He was the editor of Neboy Journal and also honorary secretary of our esteemed organization Neboy. He was the president of Guwahati chapter of AOI. He had experience of 23 years and also 40 publications in regional and national journals. He was invited as faculty for World Congress on Thyroid Cancer at USA. Dr. Rajjuti Das, he is another moderator. He is presently professor in the Department of Head and Neck Surgical Oncology at B. Borua Cancer Institute. He has more than 22 years experience in head and neck oncosurgery. He is a teacher for the MCH, Head and Neck Surgical Oncology. His special interest in oral cancer and also thyroid cancer. A keen clinical researcher and has completed some research project as principal investigator and co-principal investigator under the Department of Biotechnology, Government of India. He has over 35 peer-reviewed publications in the national and international journal. He has authored one chapter on management of carcinoma in the book Principles and Practice of Oncology. He received S. Kumar Award, also delivered S. Kumar Oration. So these are the brief introduction of our today's speaker and moderators. And now I invite Dr. Kunal Ranjan to make his presentation. Over to Dr. Kunal Ranjan.
Thank you very much, ma'am. It is my pleasure to present my presentation in front of distinguished guests and members. And I remember that the last presentation I had presented in front of Swagata ma'am way back in 2016. So it's almost 9 years.
Can you put your microphone a little closer? Because your voice is a little soft.
Hello? Am I audible, madam?
Yeah,
Yes.
yeah, this is better.
Yes.
So you can share your slide.
Yes. So today's webinar topic is applied surgical anatomy and the management of the parotid tube. So my slides are visible?
Yes.
Yes. So this topic will be covered under following subheadings: surgical anatomy, types of parotidectomies, workup, pertinent surgical steps, management of the facial nerve, management of neck, and adjuvant therapy if needed. So coming to the first and the foremost thing, the surgical anatomy. As we know that parotid gland is the largest serous salivary gland. It is ectodermal in origin. Minded that parotid is only ectodermal in origin, and the rest of the other glands like submandibular, sublingual, they are endodermal in origin. Secretion is mostly serous and watery content is high. It weighs around 25 gram and it lies in between the ramus of mandible, auditory meatus, sternocleidomastoid. It has three-sided pyramid, four surfaces and three borders. And very well, this is known as the queen of face. This facial nerve also lies here. Had there not been the facial nerve, parotid surgery had been like just excision of a lymph node or just an excision. But just because of this facial nerve, this parotid surgery is very crucial and we have to take a lot of care. Coming to the surgical relevance of this parotid gland, as I have mentioned that the secretion is mainly serous and watery. That's why stone formation is less likely as compared to the submandibular gland. We get submandibular gland stones more frequently as compared to the parotid because your submandibular gland secretion is mainly mucinous. Coming to the next slide, as it remembers as a three-sided pyramid having four surfaces, base of this pyramid, superficial, enteromedial, and the posteromedial surface, which is separated by the three borders which are anterior, posterior, and the medial border. Anteromedial surface. This surface is related to the masseter muscle, lateral surface of the temporomandibular joint, medial pterygoid muscle, and the branches of facial nerve. Posteromedial surface. This surface is related to the mastoid process with sternomastoid and posterior belly of digastric. External carotid artery enters the gland through this surface. Stelloid process, the structures attached to it, and the internal carotid artery lies deep to the stelloid process. Borders, anterior border. This separates superficial surface from the endomedial surface. Structure which emerge at this border is the parotid duct, terminal branches of the facial nerve, and transverse facial vessels. Posterior border as well as the medial border. The clinical relevance of the posterior border is that this border has to be elevated over sternocleidomastoid muscle during the initial stage of the surgery. So coming to the next most important anatomical part, that is the parotid capsule. This is derived from the investing layer of the deep cervical fascia, and it has this cervical fascia actually at the angle of mandible divides into two parts. The outer part is the superficial lamina, which is thick, and this is closely attached with the parotid gland, and it sends fibrous septa into the gland and superiorly attached with the zygomatic process. The deep lamina is a thin lamina, and it is attached to the stelloid process, mandible, and tympanic plate. The stalomandibular ligament is the condensation of the this deep lamina, and this stalomandibular ligament separates this parotid gland from the submandibular gland. What is the clinical relevance of this capsule? That's why, unlike the other gland, the parotid swellings are very painful because this parotid capsule is quite unyielding in nature over this fascia, and that's why even if we get the parotid abscess, this is not that much fluctuant as we get in case of submandibular gland and all, because this parotid fascia doesn't allow this gland to move more. Coming to the next part, that is the parotid duct. It is also known as the Stenson's duct. This is 5 centimeter in length, and this runs anteriorly on the masseter between the upper and the lower buccal branches of the facial nerve. The clinical relevance of this is that while doing various kind of head and neck surgeries, mainly your mandibulectomies and your buccal mucosa tumor, like when we have to ligate this duct, this Stenson's duct, we generally ligate it, then we have to take care of the branches of this buccal branch of the facial nerve, because this branches lies very close in relation with the parotid duct, and very high chance if due care is not taken up, we can damage these nerves. And many a times we see that after doing a mandibulectomy or your medullary surgeries, many a times patient present with the facial palsy, and the main reason of this facial palsy is that we don't care about the branches of the facial nerve which lie very close to the parotid duct. This pierces the buccal pad of fat, buccopharyngeal fascia, baxillary muscle, and it just opens at the opposite second molar tooth. Now coming to the arterial, venous, and the nerve supply and their clinical significance. The arterial supply is by the branch of this external carotid artery. The venous supply, this drains into the external jugular vein, and the lymphatic drainage is uh, via the parotid nodes into the deep cervical nodes. And nerve supply, this has got parasympathetic, sympathetic, and sensory. This parasympathetic, sympathetic, and sensory supply, this has got a clinical relevance which we will discuss in our subsequent slides. So we can see this carotid artery, the external carotid artery, which enters into the parotid gland through the posterior medial surface, and then it gives off branches. Like one branch is the transverse facial artery, which is basically the branch of the superficial temporal artery, and this branch gives supply to the parotid gland as well as to the various other structures. Now coming to the most important structure, that is the retromandibular vein, which we generally encounter during our parotid surgery. This slide I have mentioned because, first of all, this retromandibular vein is formed by the union of the superficial temporal and the maxillary vein. And this retromandibular vein then divides into the two parts. One is the anterior division, posterior division, and posterior division combines with the postauricular vein and forms the external jugular vein. The most important thing is that while doing parotidectomies, we should try to not to ligate this external jugular or the retromandibular vein early in the surgery, because once you ligate it, there will be the congestion of the gland, and generally we find that there is a lot of bleeding during the surgery. So as far as possible, if you can save this vein, then that bleeding part is bit controlled. And even if you have to ligate and excise it out, then that should be done at the later stage of the surgery. And for our postgraduate students, there is this clinical significance of this retromandibular vein also. This vein serves as the radiological marker, because as we know that there is as such no anatomical division in between the superficial and the deep lobe of the parotid. So this retromandibular vein, this flare up while doing the CCT neck or in the MRI. So this gives a landmark that which side is the superficial lobe and which side is the deep lobe. And of course, facial nerve is also one of the landmark which distinguishes between the superficial and the deep lobe. And there is one common relation in between the retromandibular vein and the facial nerve, because as soon as you encounter the retromandibular vein, you should be very careful that facial nerve and its branches will be nearby. And most of the time, like 80 to 88% of cases, this uh, vein is medial to the facial nerve. So like, while ligating this vein also and while dissecting, we should be careful that a person can encounter the facial nerve and its branches. Now, like we have discussed about the vein and arterial supply. Now coming to the nerve supply, as very well mentioned that since this gland is having secretory function and it is supplied by both sympathetic, parasympathetic, and sensory nerve. And all these fibers are carried by the auriculotemporal nerve, which is the branch of our trigeminal nerve, and mandibular division of the trigeminal nerve. And sympathetic fibers are carried by your middle laryngeal artery, and from there the sympathetic fibers run into the sweat glands which lie over the cheek skin, and parasympathetic fibers are supplied to the parotid gland. So while doing surgery, like there are if damages to these parasympathetic fibers, then while regenerating these parasympathetic fibers rely upon this sympathetic fibers, and while stimulating, once the patient gets gustatory stimulation, then these sympathetic fibers are also stimulated because of this cross connection, and we get a common condition which we call the Fraze syndrome. So that Fraze syndrome's your anatomical explanation is because of this supply only, and sensory supply is by this auriculotemporal nerve only. Now coming to the next important topic, like we talk a lot about the SMAS layer. So this is basically a superficial musculoaponeurotic system. It is a layer of tissue which is located beneath the skin and superficial to the parotid gland. It plays a crucial role in the facial expression by transmitting and amplifying muscles activity. Skin flap, the clinical significance is that while raising the cheek flap or the anterior flap over the parotidectomies, the flap should be raised below the SMAS layer so as to prevent the Fraze syndrome. So as to, because once you're after doing the surgery, with parasympathetic fibers, if there is nothing in between the skin and your this parotid bed, then there can be a chances of cross connection. So just to prevent it, not only this SMAS flap can be put, or this, like we should raise a thick flap, and many times we can put some other tissue flap like sternocleidomastoid flap or other muscular flap, so as to prevent this your anastomosis and to prevent this Fraze syndrome. So that is the clinical significance of this SMAS system, that is your superficial musculoepineuritic system. So the take-home message is that while raising the flap, this flap should be raised. Like while raising the flap, when you are raising the flap in the neck, then that flap should be subplatysmal, and at the cheek part, that flap should be below this SMAS layer. Now coming to the most important part, that is the parotid lymph nodes. Just mind it that this parotid gland is one of the glands which has got both intraparotid as well as your these nodes lie over the gland. While in case of sublingual or be it in the submandibular gland, they don't have intraglandular nodes. The nodes lie over the gland. That's why the clinical significance of this is that that's why, like, most of the time, not only parotid is a site for your the per primum neoplasm, but from different part of the bodies, like from the breast cancer, lung cancer, can also metastasize into the parotid glands. And why there are nodes in the parotid? So that goes to the embryology of the parotid, because while development of the lymphatic system develops first, and then this capsule of the parotid is formed. So, like, few of the nodes are entrapped in the parotid gland, and that leads to the your intraparotid lymph nodes formation. So this parotid lymph nodes, or this parotid gland, is the sentinel node for the temple region, side of scalp, external auditory meatus, middle ear, upper part of the cheek, eyelid. Because I have discussed this topic because while doing surgery for the various part of the malignancies, suppose we are dealing with the temporal malignancies or maybe scalp malignancies, then in such cases we should go for the superficial parotidectomy, because these nodes will yeah, the basin of these nodes will be into the parotid, and from there then they will come into the deep cervical nodes. So that's why this lymphatic supply of parotid is very important. Now coming to the facial nerve, so this I will be discussing about what are the landmarks for the facial nerve and what is its clinical significance. The first and the foremost is this tragal pointer, which lies 1.5 centimeter deep and anterior to it. So what is basically this tragal pointer? The tragal pointer is the anterior and inferior part of the tragal cartilage, and then comes to the superior border of the posterior belly of digastric tympanomastoid suture line. This lies, the nerve lies 0.6 centimeter inferior and anterior to this, and then another landmark is with retrograde dissection and combination of landmarks. So just we will discuss one by one. So like, one should not follow just one landmark, because many a times I will show in one of the subsequent slides that why I'm telling this. Because this tragal pointer, this keeps on moving. Like once you move the pinna, the position of this tragal pointer also moves. So you cannot make it out like from where this 1 to 1.5 centimeter will go on. The most important and the consistent landmark is the tympanomastoid suture line. Uh, but there is some, this is one kind of theoretical landmark we can say, because many a times for finding this tympanomastoid suture line, we have to dig quite deep into the parotid gland, and while doing that, we sometimes might injure the nerve also. And as far as this retrograde dissection is concerned, this is the best landmark. Like when we are dealing with our revision surgeries or very big tumor where we are not able to find the facial nerve, then in that case, facial nerve, the main trunk, can be you're searched from one of the branches, mainly from the marginal mandibular nerve, and then we just trace it retrogradely. So the facial nerve lies 9 mm above the superior border of posterior belly of digastric, and at the same level. Styloid process is also one of the landmark, but this is not a very good landmark. Why? Because the facial nerve lies lateral to the styloid process, and the styloid process position, its length is not uniform in every case. In some individual, the length of the styloid process can be small, and in some individual it can be large. There can be ossification, and and as I have like told that and the cystoid process lies medial to the facial nerve. So while finding this cystoid process, many a times we can injure this nerve. But this cystoid process helps us as a landmark while we are dealing with the your temporal bone malignancies, where we go for the lateral temporal bone dissection and all. Then at that time, this landmark is quite useful. And like, so coming to the your classification of the facial nerve branching. So there has been various classification. One is like by Davis et al. Because we should be very well known that facial nerves has got like, once this facial nerve gives its branches, there is a variation in that. And the first it was proposed by Davis et al. In 1956, and as per his classification, he has divided this branching into the 6 types. The most common is type 2 and type 3. Other classification is by the Katz and Kanato. This classification is important because once we are doing the surgery, we should be careful that there is nothing to just find out the 5 divisions of the nerve, but we have to look after the intercommunication in between these branches, and we should try to preserve those intercommunications, because once you damage that, there may be kind of some facial paresis and weakness. Now coming to our the next subtopic, as I have discussed about the surgical anatomy. Now coming to the classification of the parotidectomies, like very often we come to know like superficial parotidectomy, total parotidectomy, adequate parotidectomy. So this your European Salivary Gland Society has come with a very beautiful classification system, and this is based on the anatomical side. This parotid gland has been divided into the 5 levels. First is your superficial superior, that is level 1, superficial inferior level 2, then level 3, that is your deep inferior, then comes your deep superior and the accessory level. And like when you call it as a parotidectomy, like what is the definition of a parotidectomy? So as per this European Society of Salivary Gland, you call it parotidectomy once it meets the 2 conditions. First and the foremost condition is that you have to dissect the facial nerve and at least the main trunk and your one of the 2 major divisions, that is your temporofacialis or the cervicofacialis, and at least one level should be removed, and that level which I have already discussed. Parotidectomy should be differentiated or should be demarcated from the extracapsular dissection. In case of extracapsular diffraction, there is no facial nerve dissection, and less than one level is removed. So this is the ESGS proposed level of the parotidectomies, but this system is still not very popular. So coming to the next slide, what is superficial parotidectomy? The superficial parotidectomy, this implies complete removal of the parotid gland that lies superficial to the plane of facial nerve. Facial nerve is identified at the main trunk, and all branches of facial nerve are to be identified. Then we call it as the superficial parotidectomy. Next comes with adequate parotidectomy. Second name of this term is partial superficial parotidectomy. Nowadays, this term is very more oftenly used. This implies removing the tumor completely, taking care to avoid capsular rupture or nerve damage with approximately 0.5 to 1 centimeter tumor-free margin. Facial nerve is identified at the main trunk. Facial nerve branch adjacent to the tumor site is dissected and preserved. Preserves the uninvolved parotid parenchyma, obviates the need for more extensive facial nerve dissection. Benign tumors limited to the superficial lobe, preferably small pleomorphic adenoma in the tail parotid. Extracapsular dissection, same incision as we go for the superficial parotidectomy, respecting and preserving the tumor capsule. Like in this case, we have to respect and preserve the tumor capsule, because once you reach the tumor, then it becomes just enucleation of the tumor, which should not be and never done. But in this case, we don't have to identify the facial nerve once we are doing the extracapsular dissection. But in this case, the prerequisite that facial nerve monitoring should be there so as to prevent damage to the facial nerve. And this is a slide which compares your various type of the parotidectomies: partial, superficial, subtotal, superficial, total, extracapsular, and enucleation. And it has been found that enucleation should never be propagated because recurrence rate is very high, that goes up to 40 to 60%. So as we know that all annual global mean incidence of the parotid malignancies is around 1.2 per lakh, and this is the common site of recurrence. Parotid gland 70%, managed cerebellar submandibular gland 25%, and proportion of the malignancy parotid tumor 25% are malignant, and in case of minor salivary gland 65% are malignant. And the most common is the pleomorphic, and most common malignant tumor is the mucoplasmoid carcinoma. This is one classification of the parotid malignancies by the World Health Organization. So now we coming to the, like, as we have the Bethesda system for the reporting of thyroid cancer, same goes with the parotid, and this is the Milan system of reporting salivary gland patopathology, and this system should be uniformly practiced so as to like prevent or cause any kind of hassle between the pathologists. So this is the standard of care. Once a pathologist reports a parotid tumor, being it benign or malignant, that should be done under this and the criteria led by this Milan system for reporting of this salivary gland cytopathology. Coming to the next part, that is the workup. The first and foremost is the history and physical examination. First of all, like, we have to ask the patient whether the mass is slow growing or not. What is the condition of the overlying skin? What is the mobility of the mass? Facial nerve involvement is to be checked, and the contralateral cerebellar gland status is also to be noted, because many a times if contralateral nodes or the contralateral gland is enlarged, as in case of the Warthin's tumors, or in case of certain kind of autoimmune disorders like the Sjogren syndrome and other conditions also, in case of lymphoproliferative disorders, lymphoma, then we have to look for the neck examination. Oral cavity and oral pharynx examination is very important, because we have to see at the opening of the Stenson's duct, like whether there is some kind of inflammation or not, any swelling there, any secretion, any pus discharge. Oropharynx examination is also important, because sometimes this our parapharyngeal mass can also be there, and if there is deep lobe of this parotid gland involvement also, then that can present as a bulge in the oropharynx. So detailed head and neck examination is important, and general examination also important. Many a times, as I have mentioned, that parotid is a subsite for the distant metastasis also. So in case of a female, breast examination is must, because many a times we have seen that patient has presented with a parotid mass, and there was a like metastasis from the breast, or in case of CL lung also, many a times it comes to the parotid region. So the general examination is also very important in case of any parotid mass if we get in our day-to-day routine practice. So the concerning signs. What are the concerning signs which shows that parotid mass can be malignant mass? First is your facial nerve paresis, cervical lymphadenopathy. If the patient is complaining of rapid growth, pain is there, then we should be, these are the red flag signs, and that has to be fully investigated. In case of the advanced malignancies, like if there is parapharyngeal fullness, skin ulceration is there, palatal fullness, pain is there, some fistula is there, or skin ulceration is there, then that is a sign that there can be advanced T4 diseases. So how to investigate a parotid mass if a patient comes to us? Here I would like to tell that investigations complement each other. It is not that only one investigation is adequate, or one investigation is better, or USG is better, or CT scan is better. Each one has got its own importance, and each one has got its own clinical relevance as per the clinical scenario and the clinical examination. In which cases are the dynamic process, those investigations can be repeated, can be advised. It's not that if the patient comes at the same go, we have to write all the investigations. So first of all, if any patient comes with a parotid mass, so one, and cheapest and the most easiest investigation is FNAC, that is your fine needle aspiration cytology. Other investigations are like USG guidance, FNAC, core needle biopsy, CT, MRI, FDG PET, and I will be discussing each one of them one by one. FNAC in all patients, because this will change our clinical approach in 35% of patients. First of all, it will let us know whether we are dealing with the parotid mass or we are doing some kind of lymph node. As I told, that parotid site for the lymph node also. So once we are sure, then our clinical approach to that patient will change. And USG will tell us whether this is a cystic mass or solid mass, and at the same time, while doing your USG guided FNAC can be done in case of non-palpable tumor, or where we find that the tumor is quite heterogeneous, where it has both solid as well as cystic component. And then to just take the biopsy from the solid component, this USG guided FNAC can be done. But your deep lobe and parapharyngeal space is not that much accessible with this FNAC, and for that, some kind of image guiding can be done to take the biopsy from those areas. All patients do not need CT or MRI. CT mainly in case of where we find or where we suspect there can be bone destruction, or like we have to assess the nodes. MRI is better for the soft tissue delineation, parapharyngeal space, like, and if they are suspecting perineural spread, suppose there is adenoid cystic carcinoma, then in that case, of course, we go for an MRI, or we are suspecting some advanced high-grade malignancies, and we have to also like this for knowing the facial nerve status. MRI can be given. So there is one paper, and this was published in Laryngoscope, which shows that ultrasound-guided core needle biopsy of salivary gland lesions, a systematic review and meta-analysis. USG core biopsy is more invasive and it is more accurate than FNAC. But we generally in our routine practice don't do the core needle biopsy. This is indicated when your FNAC is equivocal, and when we are dealing with some lymphoid lesions, or when we want immunohistochemistry. Nowadays, even with the FNAC also, in those like centers where this facility of cell block is there, so they say that with the FNAC also they can make cell block and do this IHC, but this core needle biopsy is better to do one immunohistochemistry if we need. So in that case, we should do this core needle biopsy. Then comes the fact that when and where to go for the PET CT scan, because nowadays, like, even the patients also ask that why don't you write this PET CT scan for us? So of course, yes, this PET CT scan is not routinely done and should not be routinely used also. But in case of the high grade tumor, as you know, that this parotid malignancies, like they have very high propensity to metastasis into the lung, and this mucoepidermoid carcinoma, adenoid cystic carcinoma, and others. So in such cases, to rule out the distant metastasis, so high-grade tumors, advanced malignancy, like for the T4 diseases, or if there is cervical lymphadenopathy is there, then to rule out that PET CT. But if this PET CT facility is not available, then in that case, at least NCCT thorax should be done. X-ray chest will not suffice that, because the sensitivity and specificity of chest X-ray is not that much as with your NCCT thorax. So at least if you are dealing with the malignancies and high-grade malignancies particularly, and if this PET CT scan facility is not available, then you should at least prescribe with NCCT thorax for such patients. So this is a slide which has compared the various advantages in between USG, MRI, CT scan. So we find that tumor delineation is better in case of MRI. Bone involvement is better seen in the CT scan. Nodal metastasis, of course, it is more in MRI. PNI, histology, whether it is benign and malignant, that can also be given by this MRI. And deep lobe involvement by this MRI. Delineation is better in case of MRI. So coming to the like our next step, like surgery. So as I have discussed about the superficial patrodectomy, adequate patrodectomy, total, extracapsular resection, radical patrodectomy. In case of this radical patrodectomy, just with like not only we sacrifice the facial nerve, but we also remove other structures like skin, bone. Every effort should be made to preserve the facial nerve. We should avoid enucleation, excision biopsy, because recurrence rate is very high. Total conservative parotidectomy is like in which condition we go for the total parotidectomy. The first is that if there is deep lobe tumor, if there is high grade tumor, if there is intraparotid or cervical lymph node, or if like someone has done a surgery and the base has come as positive, then in such cases we have to do a completion surgery and we have to remove the deep lobe. Radical parotidectomy, excision, other structures other than the parotid gland and the facial nerve. Now coming to the fact like when to do the neck dissection in case of the parotid tumors. So there is as such no consensus in case of N0 neck, like whether to do for the neck dissection in case of N0 neck or not. So one school of thought is that we can go for your level 2, 3, 4 clearance in case of T3, T4 and high grade tumor. And one alternative approach is that you can send level 2 for the frozen section, and if it comes positive, then we can go for that level 1 to 5 neck dissection. So take home message is that for N0 neck, level 2 to 3, 4, and or if like you can go for wait and watch also, or you can just send level 2 and 3 or level 2 for the frozen section, and if it comes positive, then go for level 1 to 5 dissection. So the facial nerve management, the first and foremost thing is that a proper consent should be taken. This is for our postgraduate students also. Like the patient should be like properly explained about danger to damaging the facial nerve, and we cannot access or we cannot tell that whether this nerve will be involved. That decision is best taken at the time of surgery. So a proper consent should be taken. That not only it helps with medico legally, but also because that can save you from other problem. And because if you have to cut the nerve, then you cannot explain the patient that why you have cut the nerve. Like if this nerve is not functioning, then of course you should excise it out. And if the tumor is adherent to the nerve, then and its margins are involved around the nerve, then frozen section that we come to know by the frozen section, then in that case, like nerve uh, can be removed. But mind it, like suppose like your nerve is involved, and at the other side of parotid bed, if you have not done the R0 resection, then no need to cut that nerve. But because anyhow you have done a R plus resection, you have left the tumor, and patient is going to get adjuvant radiotherapy. So in that case, you have to cut the nerve if preoperatively nerve is not involved, and you find that there is intermingling or this nerve is going through the tumor, and you have cleared the tumor from every other site of the parotid bed, and that is the only site where you this tumor is there. Then in that case, that part of nerve can be sacrificed.
Dr. Kunal, sorry to interrupt you. How many slides you have now?
Sir, I think 10 slides more, sir. Just I will go fast, sir.
But the time is almost over. You have to hurriedly you have to do
Okay,
it.
okay, sir. Just I will do it
Because
fast.
we have already taken 40 minutes. I've got a instruction from the organizers also. So try
Okay,
to.
okay. So just I will try to finish it fast, sir.
Okay.
So like, how do you manage it? That is
Yeah.
your into end
No
anastomosis
need
is
to go into the depth of radiotherapy and all, I suppose.
okay, 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 sir. I will not go into depth. So like we have this
Good
jump
platform.
graph where we use hypoglossal nerve, mesenteric nerve, into sine neurography is done. Cross facial graft is also done using this sural nerve, and pertinent steps. Just in very brief, I will discuss that. That is incision, flap, extent of surgery. These are the various kind of incision. Uh, Nowadays, this modified facelift incision is used for the cosmetic purpose and for the small tumors. And this modified Bayer incision, it has got a three part. One is your preauricular mastoid and this cervical, and this flap should be raised deep to the platysma in the neck and deep to smash in cheek flap. Identify, preserve the getoauricular nerve, because at least the posterior division of the GN should be preserved. It lift the parotid of the sternocleidomastoid. Then just identify the posterior belly of digastric, trace up to mastoid, identify tragal cartilage, tragal pointer, preserve EJV and retromandibular, as I have already discussed. Use the landmark for facial. One is comfortable. Zone of interest, that is tragal pointer, upper border mastoid, injection of posterior belly of digastric. Be aware of the variation. That's why I have discussed that Katz and Catalano classification of the facial nerve branching. Dissect deep to each nerve in total parotidectomy. And one more thing, like if you are doing the total parotidectomy, don't leave behind the retromandibular surface. Many times we leave out the parotid tissue there. So the take-home message is that hold your nerve to get the nerve. Patience is key to success. This is one case which I had done 2 days back. As you're seeing that I have to do a total parotidectomy, but in this case, like this is not a modified bare incision. So the incision should be custom made, like as per the requirement. Here I have put a deltopectoral flap, so I have taken this, and in this case I had to cut the tragal cartilage also. So I'm not depending on the tragal cartilage. And just I'm using this posterior belly of digastric, as you can see it, and this nerve is coming out from the 9 mm above that, and it runs along the same plane as the superior border of the posterior belly of digastric. And complications can be like facial nerve palsy, bleeding, seroma, salivary fistula, Fraze syndrome, first bite syndrome. First bite syndrome is that like where the patient takes first bite, there is pain. That is because of this sympathetic parasympathetic mixing. Like there is loss of sympathetic fibers. So once this parasympathetic fibers they supply the myoepithelial cells of the parotid, and that leads to the pain. Once the patient takes it, the treatment is that the patient should be reassured, and we can go for some conservative or botulinum toxin and others, your anticholinergics, and those are given in case of Fraze syndrome. Adjuvant radiotherapy in very short for T3, T4 with high-grade tumor where you can find that lymph node metastasis. Chemotherapy not much role because just it is used in the palliative setting. Nowadays we are coming with the targeted therapy and very kind of like your c-kit, HER2 new receptors and all, but those have found that there is no survival benefit, and those we don't have any level 1 evidence. So with this just I conclude my slide. I think time was less. Any ask anything?
Thank you, Kunal, for your presentation. Now over to Professor Girish Mishra, sir, for your expert comment on this subject. Kunal, can you stop sharing your slide?
Yes, ma'am. Yes, I am.
Yes, Kunal, very good presentation. Tried to cover most of the aspects, and very, subtle way you've conveyed all the important points, like how to identify the facial nerve, why not to ligate IJV, why not to ligate external jugular vein or a retromandibular vein, the landmarks for the facial nerve. Good presentation. Congratulations. I think we have covered most of the parts, so there's nothing to be added up as far as this thing is concerned.
Thank you, sir. Now over to Dr. D.K. Nath, your comment on his presentation.
Thank you, madam. Very nice presentation by Dr. Kunal. Dr. Kunal Ranjan, thank you very much for elaborative presentation. But few lines I want to add. Number one, you see, parotid gland is the biggest salivary gland, and it is ectodermal, having the ductal system. If you consider the surgical anatomy, then you see the parotid gland is not a bilobar gland. It is a unilobar gland. It is separated by the facial nerve. That's why we are telling that it is bilobe. But practically there is no fascia, no capsule, any capsule between the two lobes. So it is a unilobar. Then regarding the facial nerve, 5 branches are there, and all branches are equally important. Particularly the cervical branch also important. Why I'll tell later in surgery part. Then you see that there is facial nerve, and below that there is vein, retromandibular vein, and below that there is artery. So that is important in case of surgery. You see, parotid tumor is mostly in the parotid gland, 80% in the parotid gland, 80% is benign, 80% is pleomorphic adenoma, and 80% is malignant in minor salivary glands. This is a standard rule. And if you we see the etiological part, everybody knows that the radiation exposure is there, Epstein-Barr virus is there, some chemicals are also there doing the works in the chemical factories like nickel. Then also some chromosomal translocations are also there. This is one of the etiological point. Then if you consider the investigations, this is the FNSA, which is the gold standard. Why? Because the specificity and the sensitivity is high, and specificity is very high than the sensitivity. But thing is that there are fallacies also. Sometimes there may be false negative also. So it is important that to take the adequate sample, then the interpretation must be important. The pathologist, cytopathologist must be experienced. Then if we consider the other investigations, like CT scan. Okay, ultrasonography we are doing, but in a deep loop, it is difficult to comment. Then if we go for the CT scan, already Kunal has mentioned, the lymphatics drainage, the arterial system, the venous system, the bones. These are the things that we can say by doing the CT scan. And in MRI, it is important to do in the deeper loop tumor, deep loop tumor, in the parapharyngeal. If we suspect the parapharyngeal tumor, then we can do the MRI. And one thing that Kunal has not mentioned, in MRI, we can see the boundary very well. CT scan, the tumor volume is, we can see the tumor volume. And in the MRI, we can see the boundary of the tumor. Then if we go for the PET scan, PET scan has no such rule. But for the staging of the tumor and for the subsequent follow-up, it is important. Because if we do the PET scan, that we are able to know the distant metastasis, particularly if we see the adenocystic carcinoma, then it is the propensity of the distal metastasis is very high. So the tumor may be small, there may not be any node, but distal metastasis may be there. So in that situation, the PET scan has got rule. And another also, the subsequent follow-ups PET scan is important. Again, now you the surgeries you know that already mentioned, superficial parotidectomy, adequate radical parotidectomy. So everything has been mentioned by the Kunal. But thing is that nowadays there is a concept given by Dr. Tumor Phukon. He's a professor and head of the department of Barbada Medical College. The cervical branch is very much important, as because if you identify the cervical branch and if you follow the cervical branch of the facial nerve, ultimately you will be reaching the trunk of the facial nerve. And it is the easiest method. And I have done this surgery along with the Dr. Tumor Phukon. Yes, it is really easy. And the surgery becomes very easy. Then again, the raising of the flap is important. It is fat up and fat down technique. That should be remembered to prevent the face syndrome, the gustatory sweating. So fat up and fat down, it is important. Actually, parotid surgery is nothing but the dissection of the facial nerve, and the parotid mass is the byproduct. That is the concept. Then if we go for the neck dissection mentioned by Dr. Kunal, so I am not going to tell in details. And another point is I want to tell regarding the nodes, the interparotid nodes. It is important because of this skin cancer also that he has not mentioned. Now, in European countries, maximum of skin cancers are there, and they are doing the parotid surgery at the same time, as because the intraparotid nodes are the first echelon of the skin cancers. That is important. Then again, regarding the neck dissection, already he has mentioned everything. But one thing I just want to say, if there is paralysis of the facial nerve, then neck dissection is a mandatory procedure. Again, if we consider the chemotherapy, no rule as such, that still as a palliative, in a palliative setting, we can give the medicine like zefitinib, but targeted therapy still in the phase 2 trial. Then the radiation must be given in case of high grade tumor, high T, that means T3 and T4. We can give the radiation, PNI. If there is PNI also, then we can give the radiation. Then if there is lymphovascular invasion, then radiation is important. These are the points for radiation. And one thing I just forgot to tell, the MRI, in MRI, we can see the involvement of the nerve, facial nerve. Then the surgical surgery will be different, as because you see, if we cannot free the facial nerve from the tumor, then we have to sacrifice the facial nerve. That is important, and that can be ruled out by doing the MRI also. So these are the points briefly I have mentioned, and I think the Rajit is more expert, Mr. Sir is there, then they will tell some more points. Okay, thank you.
I think.
Thank you. Thank you.
Hello.
Yes,
Can you
sir.
hear?
Yes,
This
sir.
use of microscope is also quite helpful sometimes in identification of the facial nerve. Plus, those interconnections between the branches, which he emphasized upon, has to be preserved, because just identifying the 5 divisions and preserving is not enough. The interconnections, according to the classification, have also to be preserved, and that can be done better under microscope than under loop or in a naked eye. So that point has to be emphasized. And PET scan, so far as concerned, if there is a metastasis to the parotid from other sites, which you mentioned already, has a role to play. If you are suspecting some primary elsewhere which has got metastasized into the parotid, then PET scan will have a role to play preoperatively. These are the two important.
One thing one thing I just want to add, that in case of redo surgery, always the nerve monitoring is important, and always you have to follow this rule. In case of redo surgery of the parotid, that is very much important.
Thank you, Dr. Dhiren Nath. Over to Dr. Rajyoti. So, can you give your comment on this presentation? Also, there are lots of questions are coming in the chat box, so we have to take up those questions also.
Okay, I'll just quickly finish with touching few points. Kunal, a lucid presentation. Sorry for interrupting. We could have given you half an hour more. You could have gone speaking. Next time we will do that. So, as Dhirendra has pointed out, you have left behind a little bit of topic regarding the cause of the parotid tumor, like risk factors, smoking, virus, then older age group, radiation, then rubber and nickel exposure. These are taken to be the high risk factor for occurrence of parotid tumor malignancy. Then secondly, FNAC and corneal biopsy. Now, when to choose for FNAC and when to choose for corneal biopsy, decision is on the surgeon's point of view. Because if you get a good diagnosis in FNAC, your likelihood of going for core biopsy is not required. But once you get a heterogeneous picture in a fine needle aspiration biopsy, then you should go for corneal biopsy. Secondly, if you have to choose for MRI and CT scan, which is better? In which cases you will choose for MRI and in which cases you will go for CT scan? Can you tell me, Kunal, in which cases you can go for MRI and which cases you will go for CT scan?
Decision whether we should go for CT scan or MRI, that is, first of all, we have to examine the patient. We have to see what is the stage of the disease, and if you are suspecting there is some bone erosion, the mandibular bone is there, or if it is going into the skull base, in that case It's not
Suppose
that.
it's a tumor located to parotid gland, there is no involvement of bone. You will go for CT scan or MRI.
Ideally, we should go for a MRI because this will give a better soft tissue delineation. And as I have mentioned in my presentation in my one of the slides, that your MRI has the advantages over the CT scan, just but it is in case of the bone erosion only, because in case of MRI this has a better sensitivity, so it gives a false positive rate. Even if there is no bone erosion, then in that case this MRI will show like as a bone erosion because it is more sensitive than this CT scan. So
MRI give you 3 points more important than CT scan. One is the margins of the tumor, whether it's regular or irregular. Secondly, the condition of the nerve, whether there is perineural spread or not. And secondly, the morphology of the tumor. What is the morphology of the tumor? What is a homogeneous tumor or heterogeneous tumor? Because homogeneous tumors are mostly found in the benign lesion, heterogeneous tumors are mostly found in the malignant lesion. So these are the 3 advantages of MRI over CT scan. Secondly, nowadays there is an advancement of MRI. New techniques are coming up. Whether you are aware or not, I don't know. It is called radionomics. There are some molecular biological MRI scans where you get the morphology more accurately than the existing normal MRIs. So this is in pipeline now. People are using it to get good morphological diagnosis to compare between benign and malignant, because the radionomics MRI scans are done before the contrast is injected, during the contrast is injected, and after the contrast is injected. So you get 3 or 4 curves. Accordingly, you can take a decision regarding the malignancy strength of the tumor in confusing state. Secondly,
one more point just I want to add, like in case of dealing with the malignancy, as very well, this is not that tumor should be like that. Management depends on the 3 factors. One is your tumor factor, management factor, and the patient factor. So we have to take in account everything, and then accordingly we have to guide the patient. Suppose like in some facilities I have mentioned that if imaging of camera is suppose not available or patient cannot afford, then it is not that, then accordingly we can plan. But yes, of course.
No, that is a different issue. I'm just asking proper. Secondly, what is the role of cross-sectional imaging in a superficial lobe? Can you tell me? In a superficial lobe, in which histology you will go for cross-sectional imaging? Suppose you have got a superficial lobe tumor which has been detected, but in a histological features you will go for cross-sectional imaging.
Sorry,
can you tell me? Suppose you have done an ultrasound, you have got a 2 by 2 centimeter tumor in the superficial lobe. Okay. Nothing is, ultrasound says nothing is there in the deep lobe. Clinical finding is normal, but histology will tell you something that you go for cross-sectional imaging even if the tumor is small. Can you tell me the histological type? Which type?
So, like in case of, as I have told, in case of the high-grade tumor, in case of adenoid cystic carcinoma, irrespective of its grade, is very high-grade tumor. So in that cases, like in case of the mucodermoid case, and in case of like suppose there is a low-grade carcinoma like ethnic carcinoma and all, where we find it is a very small, limited to the tail of parotid, then in that case, I might not go for
You're correct. You're correct, Kunal. But poorly differentiated carcinoma and undifferentiated carcinoma, high-grade tumor means of this differentiation. Along with there is a lymph node involvement in the deep lobe also. So ultrasound will not be able to detect the lymph node in the deep lobe. So we'll be missing the tumor in the deep lobe also. So in the high-grade tumor like poorly differentiated and undifferentiated tumor, even in the small tumor, ultrasound says it's a small tumor located to superficial lobe. Still, you should go for cross-sectional biopsy. Secondly, in cases of prophylactic parotidectomy, one is your cutaneous malignancy, and most commonly we are encountered in the eyelid malignancies also. Because we are encountering a lot of referral cases for eyelid malignancy. In those cases, when the skin of the eyelid is involved, then we should go for a prophylactic parotidectomy. Secondly, the role of PET scan. As Dhirendra has said, ethnocystic carcinoma, we should go for a PET scan. But okay, the PET scan is mostly for diagnostic purpose only. Because even there are a lot of literatures coming up nowadays. If there is a metastatic lesion, 3 or 5 metastatic lesion in relation to an ethnocystic carcinoma, still the management of treatment will be the same. So it's called oligometastatic disease. Because most of the metastatic lesions in the ethmocystic carcinomas are indolent like thyroid carcinomas. People will live longer for 5 years, 10 years if you remove the parotid tumors. So PET scan in those cases are mostly for diagnostic purpose rather than any change in the management.
Dr. Rajyoti, there are some questions in the chat box because we actually crossed our timing.
Yeah.
Can you take up those questions because we have to entertain our members as well, participants as well. So,
ma'am, Anjana ma'am, just I want to ask any question to Raj, or I want to tell. Thing is that in case of PET scan, that there is problem also. Then in Warthin's tumor, pleomorphic adenoma, in the inflammatory mass also, the FDG uptake is there. So it is very difficult to say sometimes it is malignant or not. So in that situation, you cannot say that PET-CT is very much important tool for us for diagnosing the parotid tumor. That is important.
Parotid tumor on diagnostic purpose doesn't have got role as a PET scan, but PET scan has a role in recurrent tumor, high-grade tumor. If you want to counsel the patient, if you want to see what is the status of the disease, in those cases, once you are going for molecular marker testing, going for targeted therapy, then only to see the response, PET scan has got importance. In diagnostic purpose, parotid and salivary tumors have very, very limited role as far as the PET scan is concerned.
That's true.
Okay. Can we accept the questions?
Yeah, we'll take the questions.
Okay. So can you go through the questions, Kunal or Rajyoti? So should I? The first question is coming from Dr. S.V. Fukan, on whose name the facial-venous plan is coined.
Question to Kunal.
Question to Kunal.
Petis venous plexus, if I'm right. Petis, call it.
Okay, S.V. Fukan sir.
Petis facial-venous plexus.
Right. He is asking again.
Correct.
Am I right, Fukan sir?
Yeah, correct.
So one more question. Pseudopodal extension is still blamed for recurrence? Sir is asking again. What do you pseudopodal extension is still blamed for recurrence? He was asking.
It is right, because like these pseudopods, if you are not doing a proper parotid surgery, like if you are not taking a normal parotid tissue around the tumor, because this capsule is not a complete capsule. Many cases, like there is breaches and that continue. So like if that part of pseudopod is left behind, then that will lead to the your recurrence, because of that capsular breach, and that capsule is not intact at every places, and there is your intercommunication in between this tumor as well as this normal tissue. So we should try to take out like a few millimeter of this normal parotid tissue, even if you are like dealing with this pleomorphic adenoma or this.
Dr. Kunal, just I want to add one thing. So in recurrence, it is very difficult to say what are the causes of the recurrence. But because you see, for the inadequate surgery, there may be recurrence. In adequate surgery also, there may be recurrence, tumor recurrence. And the thing is that there is something, the spillage is there. So that is one of the causes. But you see, till now that this is difficult to say why the pleomorphic adenoma recurrence is there.
There is also one point we should look into it. While lifting the flap, we should not be taking any amount of glandular tissue into the flap. You should be 101% careful, because that few millimeters of glandular tissue in the flap might give you a recurrence, whether it's a benign or malignant tumor. So you should be very meticulous in lifting the superficial flap also.
Capsule should not be breached. Like
capsule should not.
That is the most important thing. Because once you break the capsule, then of course the chances increase.
Second question is, madam, I suppose it's Milan or AGCC or WHO classification which is more informative. Kunal, you want to take this question?
What is the question, sir? Sorry. This is
Milan system, AGCC, WHO classification which is more informative.
Like I think each one of them has their own relevance. If I'm right, your AGCCs for your tumor staging, like whether it is your T1, T2, T3, T4, and Milan has been made to make a common consensus among the pathologists because parotid tumor is very difficult to like report, like as there can be one uniformity. So each one of them has got their own importance and clinical significance. Your AGCC is mainly deals with your the clinical aspect of the tumor, and your Milan mainly with your pathology. So if given a chance, then of course Milan, if it is like properly reported, then because like your the pathology is going to lead us our planning, like whether we are going for a superficial or we are going for a total pyrectomy, whether there will be uh, like your need of any adjuvant therapy and other things.
Swagata ma'am is asking, have you ever
uh,
encountered parotid fistula? If yes, how do you manage it?
Jana madam, can I just make a point in the previous question of Kunal, what
Okay.
Kunal has spoken?
Okay, go
The
ahead.
Milan system is mostly clinician friendly, and it gives you idea regarding the aggressiveness. Likewise, we get in thyroid rate of risk of malignancy. So Milan is something like that. So AGCC, what Kunal says, is clinical, and WHO is mostly the histopathological diagnosis of classification. Thank you.
So Swagata ma'am was asking about the parotid fistula. Have you ever encountered, and how do you deal with?
Or other way around, what is the disadvantage of taking an open biopsy? Kunal?
Yes, sir. This parotid fistula, yes, 3 or 4 times I have got, like mainly in case of traumatic cases. Many a times we get a your panfacial trauma. In that case, if there is damage to the parotid gland or it's ductal damage, or in case of surgery also, many a times like here I want to just correlate it. As you know, this parotid gland, 80% of secretion is by your superficial lobe. So once you are doing the superficial parotidectomy, there is no need of your tying your that extension step. But in case of like if you are getting your adequate or your less than superficial and lot of tissue handling and damage to this duct, that sometimes can lead to this your seal, and if not managed, that can lead to this your parotid fistula. The management conservatively, what like compression dressing, anticholinergics have been tried, and most of the time it has been seen that they are managed. But in those cases, which are like not responding to this our conservative management, then in that cases we have to like go for the superficial carotidectomy, and in 2-3 cases I have done superficial carotidectomy for it.
Thank you.
Kunal, have you done an open biopsy in a parotid case? If
Uh,
yes, why? No,
yes,
why?
yeah, of course, yes, of course. Like, I have done in that case of like T4 cases, like advanced cases where there is fungating skin mass. Like I am sure this
No, no.
patient is
I'm asking you. Have you done a open biopsy in a parotid case with the intact skin?
no, sir, so
No,
far I have not done, sir.
no, no, not done. Then why it is
Not
not
done.
practiced? Can you tell me?
Yes, sir. One thing like theoretically, one say ki there is this your tumor seedling, and suppose there is intact skin, then you are just breaking the barrier or breaching the skin barrier of the tumor. Okay, first point. And second, it can lead to this parotid fistula also, and your tuber spillage is there. And nowadays we have other means of doing that. We can go for the image guided or the USG guided or the core needle biopsies, which is less invasive than this your open biopsies. And nowadays we generally try not to do that invasive procedures, and that will not give us more headache. And of course, one more thing is that there is a very high chance of damaging the facial nerve also, because the nerves with run and like while doing this biopsy, like you can cut any of the branches. So this is not practiced.
So
Dr.
one
Kunal,
question from Dr. Pradeep Sekia. So pleomorphic adenoma of deep lobe, how do you manage?
That I will go for the total parotidectomy only, because one thing is that your pleomorphic adenoma is also known for its because as you know that deep lobe is a very small part of the gland, and there are these pseudopods, and just to your preserve the nerve and to your decrease the chances of recurrence in future, I will go for total parotidectomy in case. So Rajyoti sir, your comment?
Dr. Kunal.
Yeah, it's a
Dr.
total
Kunal.
parotidectomy only. Approach
Yes.
is from external to medial.
Yes.
Total parotidectomy will be suffice. Kunal, can you tell me what is curtain sign? This is for general public also, because this is very initial workup for a parotid. No, that's why I'm asking you.
But if I'm right, because of its attachment to the zygomatic arch, it is not that much.
Yeah, you're correct. Correct.
Okay, okay, I think.
Deep pasa is connected to the zygomatic arch, so you cannot move
That
the.
is not that much mobile, and as I've told, that's why your parotid tumors are very unyielding. It is not that much mobile, and
This is another relation to if there is a tumor in the deep lobe of the parotid, this will be a positive. So this is in relation to that I have asked you.
okay.
So one question from Vishwajit Gogoi, how we can optimize adequate during parotidectomy? Any thumb rule?
কি সুধিছে বিশ্বই বুজি পোৱা নাই
How, Bishop, can you unmute yourself? He
Bishop,
was
can you
asking how we can optimize adequate
He asking
during
adequate
parotidectomy.
parotidectomy.
Any thumb rule?
Adequate parotidectomy, he is asking.
Yes, adequate parotidectomy mainly for, like, if there is a very small tumor that only in your tail of the parotid, it's benign tumor, then in that case, like we have to, because the basic concept of adequate parotidectomy is that not to do much more damage to the nerve,
Correct.
and just to identify the main trunk of the nerve and do a limited dissection with a cup of tissue, maybe your 2 to 3 mm around the tumor mass, and like, then we do it for your very small. And in case of, like, some literature and some paper has shown that for a very low grade tumor,
Malignancy.
T2 tumor also, this surgery is being done or propagated.
It is all depends upon what amount of cuff normality leave behind after a adequate parotidectomy.
Yes, so the main
As you have rightly said, it's a small tumor, benign tumor in the tail of the parotid. Very small malignancy, low-grade tumor, malignant tumor in the tail of the
systemic cell
parotid.
carcinoma and all.
Yeah. And most of the time, Kunal, what I think is that you need not expose the nerve always, facial trunk.
Main concept of
Because see, location of the nerve will be deep behind the superficial lobe. So unnecessary dissection is required. So you have to be preoperatively careful to select the cases that these tumors are not in the vicinity of the fibers of the facial nerve. Then only you can just dissect them without identifying the nerve. That's why it's called adequate.
No, sir. Just one point I would add it. Like, once you call it parotidectomy, as I very well mentioned in my presentation, to call it as a parotidectomy, you have to identify the main trunk of the facial nerve. If you don't do it, then just don't call it. Then it will be called as extracapsular dissection. Like, to call it parotidectomy as per your European Society of Salivary Gland, like, you have to identify the main trunk, and then you have to do a limited. Suppose there is a very small tumor, then I will not go and dissecting the cervicofacial, temporofacial branch. I will just do a minimum dissection around maybe around your marginal mandibular or just location of the tumor, and I will not hinder, so that, because that is not going to give me any extra benefit. That is the main concept.
Am I audible?
Kunal, the statement I have made, this is a statement from the Jotin South.
The intention of asking this question, what I'm expecting, it maybe I write down as adequate parotidectomy, but the dissection by you is maybe different from my dissection. So how my histopathologist know that is the same adequate things that he is sending for? Maybe the Dhirennath sir dissection may be different. So I don't know. I'm a very benign surgeon of.
No. So what I meant to say is that once you leave behind a normal cuff of tissue around your tumor, which is oncologically safe.
How do you know it's a normal cuff? how will you know this, sir?
Listen
How
to
will
me.
you search? How will you ask?
Let me complete. You are
Ah.
not going to take a 1 centimeter of tissue around the tumor. It's a benign tumor. You are going to take a normal centimeter, maybe in
2
millimeters
to
of
3 millimeter traces, sir.
millimeter. It's around 3 to 5
It says 2 to
millimeters.
3 millimeter only.
It's not someone's discretion that you will say this is parotid, I will take 7 millimeter, this is my parotid. That is not the discretion of someone else. It is the discretion of the tumor. This is the normal tissue in the parotid gland. You are not going to take 1 centimeter in and around the tumor, mostly in the benign tumor. Malignant tumor issue may be something different. We may be going up to the 5 millimeters also. That's why the indications are small tumor, low-grade tumors. So this is the discretion of the tumor itself, not the discretion of the surgeon.
Dr. Ranjit Kumar Lal has actually he has mentioned regarding parotid fistula pressure dressing and anticholinergic helpful in post-surgery fistula. Are you
Yes.
agree with this?
Yes. Most of the time, this will lead to controlling of this fistula.
He was asking co-needle biopsies can be subjected to ISC.
Yes.
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 Of course. The main role of doing a co-needle biopsy in a confusing heterogeneous group of parotid tumors where FNAC is not conclusive. So you can go ahead with IC as per requirement.
True.
Then you
Core
can
biopsy.
core biopsy.
So
one more thing I like to add during for parotid fistula is that if it doesn't control with your all this conservative treatment, you can just put a local flap over that tissue and you can close the defect rather than continuing the conservative treatment and all.
Yeah, I think so.
So we have completed the entire questions that were put in the chat box.
Madam, I have mostly one more question. What is the
non-functioning nerve? No, okay.
What is the definition of non-functioning nerve, Kunal? I am asking definition.
Yeah, that exact definition I don't know, sir. But to my knowledge, non-functioning, if there is any kind of paralysis of the nerve.
Vishwa, will you share with us the definition, Vishwa?
Vishwa?
Sorry, definition.
Because I have, I don't know, but he is mentioning non-functioning. That's maybe it's a combination of.
Non-functioning nerve is a clinical definition. I don't think there is a definition for it.
Maybe it's a, I don't know. That's a clinical definition.
Some criteria to call it as a non-functioning nerve. Looking into the tumor and there are some criteria. And I don't think there is a definition as far as my knowledge goes.
If the nerve is paralyzed.
Sir, paralysis is different. Sir,
paralyzed is different, but if the nerve is not conducting the sensations, then it is non-functioning nerve.
Exactly, sir. Maybe that combination of electrophysiological tests and maybe that.
Maybe that it is not involved by the tumor, but because of the pressure, long-standing pressure, it may stop conducting the.
Electromyography can help. I don't know.
EMG and EOG can help you too.
No, that is just diagnosis. Even the non-functioning nerve is not cut nowadays. Until unless it is very hardly involved by the tumor, high aggressive tumor. Most of the
I can share one presentation from Vijayendra regarding this aspect, both electrophysiological.
This is the same philosophy used in the non-functioning nerve also.
Maybe.
The same electrophysiological study also the same. So same is followed in thyroid also. Any nerve that is not conducting electricity directly, you cannot cut it at the same way. You have to look into multiple factors to consider it as a non-functioning nerve.
Yes.
And some of this nerve is to control the muscles of facial expression, basically. Okay. Of course, and that can be because of this electrophysiological.
Because there is a time period that most of the fiber will regenerate after the inflammation goes off. So non-functioning nerve may regenerate up to 30%, it may regenerate up to 60%, something like that.
If the nerve is not involved by the tumor grossly, if you can dissect the tumor off the nerve, even if it is non-functioning, you don't have to resect it. You preserve that nerve so that with the hope of it getting regenerated in future.
Yes, sir.
Kunal,
yes, sir.
Just last question. When you cut the nerve when it is not involved by the tumor?
Okay.
And if you cannot answer it, it's a homework for you.
So
he has presented nicely everything in.
He is very talented, madam. He is very talented.
Kunal, you have to describe about adequate parotidectomy. When we do adequate parotidectomy in the tail of the parotid, we must dissect the facial nerve, no? To call
Yes, sir.
it.
Yes, as I have told you, as per your
Yeah.
the guideline to call it as a parotidectomy, be it
Yeah.
your total or your superficial or your adequate,
Yeah.
then at least you have to dissect the main trunk and it's one of the two your
No, but
divisions of this facial nerve.
Cervicofacial branch.
Sorry to interfere.
Yeah, yeah.
But if there is a Warthin's tumor at the tail of parotid,
Yeah, that is I am telling.
wherein you are not going to touch the facial nerve in any case, you can just
Yes,
excise
yes.
the tumor
That
with
will
the
be called as
capsule
your extra
without
capsule.
removing normal cuff of tissue as well. So what do you
Yes.
call it? Excision of tumor. That's it.
No need, I think.
Then, sir, the terminology for that is your extra capsular dissection. Then that will be
Right.
not called as your
So,
adequate.
Kunal, your
Yes.
adequate parotidectomy may not be always extracapsular like you do in a superficial parotidectomy.
No.
And the
My,
statement what Bhukan sir has asked, was
sir,
made
my
by Jatin
concept
sir.
is it's all about the definition. Like there are certain guidelines.
Okay.
Like there are three things. One is your enucleation, which we don't do and what should not do. In that case, just to cut the capsule and tumor will come out, which at many the quack people generally do.
Right.
Maybe at the periphery. Then comes with extracapsular dissection. The prerequisite of doing extracapsular dissection is that you should have a facial nerve monitoring. Like you are not very close to the nerve, that will lead to you, because the morbidity with the extracapsular dissection is very less, because there is no chances of Fraze syndrome and other thing, because there is your Prisma guideline. In that case, like 3,500 patients they have seen, and they have found that your loco-regional control is same whether it is your extracapsular dissection or your superficial, sorry, your adequate parotidectomy. Yes, but in case of enucleation, that I have told that 40 to 60% recurrence chances. To call it as a parotidectomy, that guideline which like facial nerve dissection and your one of the level of that anatomical level of this parotid gland should be dissected out.
When you do extracapsular dissection, suppose the facial nerve dissection, it
Yes.
becomes not extracapsular already.
No,
Do
like
you think?
once you have found out the facial nerve or dissected it, then
Yeah.
it will, depending upon the level. If you're removing all like your, I think you should go with that slide. There I have mentioned like your all the 5 branches of facial nerve. If we are dissecting it off and certain levels of parotid gland are removed, then it is superficial parotidectomy. And just we are finding out the main trunk of facial nerve and dissecting one of the two divisions of the facial nerve depending on the location of tumor site. Suppose there is a very small tumor which is lied very close to your temporofacial division of the facial nerve. Then in that case, you don't need to go and divide and dissect along the marginal mandibular nerve. If it is
Right.
along your tail of parotid, then in that case you will go and divide and dissect along the marginal nerve. So that is the main.
Kunal,
Yes.
practically it is not very easy to dissect the tumor which is along the temporal branch without identifying the main trunk.
That is what I'm telling you. Like
You
you
have to
have to
identify the
identify.
main
Yes,
trunk and follow it upwards. That
that
becomes
is
a
what I'm
dissection
telling,
of the
sir. That
entire
is what I'm
facial
telling.
nerve.
You have to identify in every case the main trunk.
Yeah.
Main trunk has to be identified in each and every case, and then depending upon the location, you have to follow whether
Tumor
your
removal may be according to location, but the
right.
main trunk has to be
Yes,
identified to
main trunk
identify the
has
two
to be identified.
divisions.
Then only you can call it as a parotidectomy. If
Even
you
if
are
you
not
have a monitor, it is not easy to identify one particular trunk by the monitor leaving without identifying the main
that
trunk.
is what like the main concept
Yeah.
of extracapsular dissection was like, suppose very small tumor and you have that nerve monitoring which will let you know ki, like you are not very close to the nerve and you are taking out the tumor with a small cup of normal tissue. But of course, there is very high chance of damaging the nerve in
These
case
are
of.
all terms used to confuse the subject more,
Yes,
and
yes. So these are
creating
all a bit
confusion
theoretical
amongst the
things.
This
juniors.
is
These are very theoretical things.
Yes, yes,
Kunal.
correct.
Yes, sir.
Everybody is saying about the recurrence after extracapsular excision. How many cases you get after recurrence after extracapsular
Yes.
excision?
The data which has shown.
No, not data. Your experience.
Yes.
My experience is that have
So far, I
rarely
have
come
not done
across
even
any
a single
recurrence.
extracapsular dissection. In every case, I first of all dissect out the main trunk of the facial nerve, and I don't use nerve monitor also, and data also shows there is not much advantage compared to the manual finding and the nerve monitoring. So extracapsular dissection I have not done. Either I have done adequate parotidectomy, superficial, and other.
Dr.
Minimum.
Kunal.
If it is a case of a 70 years patient with a benign tumor at the tail of the parotid, what you will do? Are you going for the superficial parotidectomy, or you will go for extracapsular excision?
I will go with the adequate parotidectomy.
Okay.
If I have the nerve with monitoring facility and expertise, then I will definitely go with the extracapsular. If I don't have with nerve monitor, then in that case, anyhow, I will try to find out the nerve, and then accordingly, if there is a very small, then I will go with that is your less than superficial parotidectomy or the adequate parotidectomy.
Dr. Kunal, just I want to ask one question. Is there any concept of nowadays enucleation of the tumor? Because you
No,
see,
no,
some people are
no.
still.
Enucleation concept is completely gone, Dhirendra, from
Enucleation
thyroid
is
and
quite
parotid.
absurd thing because
As like thyroid, it's a
in case
heavy
of
thyroid. It's
enucleation,
like
you're
parotid, it's a superficial parotid.
right, because just you give one incision over the capsule and the tumor pops out. So the data shows that 40 to 60% chances of recurrence is there in case of enucleation.
Even more than that also.
Yes.
Once
Enucleation
you
is not practiced.
by enucleation, you be sure that 80% that patient will come back to you, will go back to somebody else.
Yes. The
Okay,
minimum.
sir.
So the take-home message.
I think we have already ahead of
Cross.
30 minutes. Our discussion is very nice, and if we continue it, it will go. So
Another 1 hour.
another 1
Actually, we made a mistake. We should have
this is
divided into
discussion.
2 classes.
I think everyone in this benefited by this webinar, and it's a very fruitful discussion. And thank you, everyone. Anjana,
So,
can you
yeah.
give the
Yes.
official vote of thanks?
So just want to, for the information, our Girish, Mr. Sir, this is 26th Neboy classroom, sir. We are organizing it very regularly. So twice in a month, this is the 26th classes.
Great.
We have a website and it's all classes are live in the YouTube. If you get time, you can go through it.
Sure.
And
Congratulations for that.
yeah, thank.
And I
So
appreciate the invitation, and I thank you. We feel privileged about being part of this
so
association.
we are honored by your presence, sir.
Thank you so much.
Thank you, sir. And I would like to also thank Dr. Kunal. And we are Northeast is proud of you because you have done all your studies here and from Northeast only. And you are doing. I have heard that you are doing a great job there in. So it's a great presentation. Everybody will be benefited from your presentation, and would love to hear you from again and again. And I hope you will come to Neboy to for with your presentation. Okay, and I would like to thank Dr. Dhiren Nath for your inputs and also to Dr. Rajuti Das for your input into the subject. And I thank everyone who were present here in this Neboy classroom because today actually we crossed 1.5 hour. Still nobody has left the class. Everybody from beginning they are listening to your presentation. Thank you all the participants for your presence. And with that, we conclude our presentation, classroom here. Thank you everyone for joining.
Thank you very much.
Good night, everyone.
Thank you, everyone.